Good evening to one and all present here. One person who is considered to be the Marco Polo of physiotherapy, today a Dronacharya for many ankle events. Mr.A.G.Dhandapani sir completed his course from Government College of Physiotherapy, Chennai in the year 1973, underwent manual therapy training in the United Kingdom in the year 1992. He has been an academician from 1977 to the year 2009 as assistant professor, additional professor, and professor. Retired as the principal of College of Physiotherapy, Sri Ramachandra University, Chennai. Over to Dhandapani sir for the session.
Thank you. Not all of you, because it's not the last slide, it is the first slide. I'm thanking Almighty for giving me the opportunity to be here amongst teachers of mine, my colleagues, my students, and young budding physiotherapists. Education should bring change in an individual. That's the main purpose of education. It should bring cognitive aspect. So one should gain knowledge. Once you get knowledge, that's not sufficient, and it also should be reflected in skill development. Finally, both knowledge and skill should bring about a permanent change within an individual. So the permanent change is the ultimate result of any education. So when all of you will agree that when you join first year, how you were, when you come out, how you change yourself. You have to transform yourself to be a good professional. That's what the idea of giving this slide as such. And in cognitive domain, the knowledge is gained and it is being comprehended and it is being applied whenever needed during discussion period as well as during communication with others. And analyze the discussion, synthesize them, then evaluate your discussion. That is the main idea of the cognitive domain. Whereas psychomotor domain is nothing but development of skill, which is imitation. When you try to learn something, you have to imitate somebody, like driving or doing practicals, etc. Then as you practice, the automatism comes, then with the control, with the skill, you try to do that one. That is the psychomotor domain. Whereas the affective domain is very important because it's not sufficient only to gain knowledge, to have a good practical skill. You should have an attitude of receiving people's ideas and respond to their ideas, then value their ideas, then organization, how to organize your workplace, etc. Then the most important is characterization, that is a professionalism. Then all those things joined together makes the value complex. So these three domains of education is important for anyone who goes for higher education, not only higher education, even any type of education as such. So with this preamble, I would like to go to the main topic of the day. My respects to all for this today's topic, and I appreciate the people who have responded and registered themselves for this webinar. And when Mr. Amal approached me to talk, I said, whatever you choose, you can ask me to do. So he chosen the clinical reasoning. So the clinical reasoning is a component of clinical decision making as such. And the main objective of clinical reasoning is at the end of the talk, you will be able to define clinical reasoning and clinical decision making. Though the clinical reasoning is part of a component of clinical decision making, for convenience sake, it has been just, we'll try to discuss in two different aspects. The first one is a clinical reasoning. And we should be able to understand the strategies and steps to be followed in the process of clinical reasoning and clinical decision making. So you can understand that the word process is very important here, because the clinical reasoning or any work in clinical reasoning is not a an activity. It is a process. It's a continuous one. If you keep on changing, always a process is a dynamic one. So clinical reasoning and clinical decision making, you can call it them as a dynamic clinical reasoning process as such. Understand the major components of clinical reasoning. Create opportunities in clinical practice to develop reasoning skills and demonstrate ability to reason during assessment and ongoing treatment of patients, and demonstrate ability to actively communicate with the patient. Recognize problems that can occur during communication. This is very important. We'll try to go a little bit deep later on the during discussion. And conduct a focused and informative subjective examination. So don't think that clinical reasoning is a new concept. It has been there forever in health sector. Those days we learned that it is the case record where the patient's profile is taken and history is written, all the tests are past history, present history, family history, those, and finally a diagnosis will be written followed by treatment. So the same process is being divided into a different way, like a subjective examination as well as objective examination, following certain steps, so that gives an opportunity for the clinician to think and apply his or her knowledge for the better management of the patient. And the most important is the label the patient in a clinical group. Let us see what is about it. And one should be able to formulate the hypothesis. All of you will agree with me, we physiotherapists do not treat the disease. When I say the disease, the medical community give a label for a patient as a disease like hypertension or stroke patient or osteoarthritis knee, cervical spondylosis. But we physiotherapists don't treat the condition labeled as cervical spondylosis, etc. We treat the resultant of such health problems. So in that, there are many aspects that we'll see later on, that for which you need to formulate an hypothesis. What is that one? This formulating hypothesis, some authorities call them as a working hypothesis or clinical diagnosis, etc., etc. Here in this discussion, it is being named after the hypothesis. And basing upon the hypothesis, we try to choose appropriate tests and measures to confirm the hypothesis. Once you think it could be this, then it has to be proved. That's what exactly happening in the last step of clinical decision making, in clinical reasoning. So the confirmation of hypothesis gives an opportunity for the therapist to choose an appropriate test and measures, which is the next step, which that will not be covered today as such. It enables us to critically evaluate and improve our clinical skill as well as clinical reasoning abilities. So once you talk to your patient to gain some data, you have to evaluate them and try to reason clinically why it's happening. For example, a small example I'll give you, Anila. If a patient comes with a referral or directly to you, you think that it is being diagnosed as an osteoarthritis knee joint. As I said earlier, we don't treat the osteoarthritis as such. We treat the problems due to the osteoarthritis, that is, it could be pain, it could be the joint range problem, it could be a muscle or muscle efficiency problem, etc., etc. So in that, we have to find out what is that, whether the individual patient is having problem with joint range or the muscle efficiency or pain as such. It could be anything or more than one thing also. So that is what exactly is the main idea of doing a clinical reasoning as such. So for which there are certain strategies we have to follow. You will see that. That is a small question I leave to you all. Is research in thinking or reasoning and nature of expertise lacking in physiotherapy? I would say yes, there is a lot of gap between logical thinking and reasoning, but for the past 2 decades, the scenario is changing because people started following the clinical reasoning skill in all areas. So slowly the research is coming. The problem in clinical reasoning is putting a clinical diagnosis terminology. That becomes an issue here. Going to the definition, Hicks and Jones in 2000 has said clinical reasoning has been defined as a process in which the therapist interacting with the patient and significant others. When you say significant others, it could be family members, caregivers, or healthcare team members. Health management strategies based on clinical data, client choices, and professional judgment and knowledge. This is a definition. But they themselves have given, Ms. Jones has given a definition earlier in 1994. The clinical reasoning process is a description of the actions and evolving thoughts used by a clinician to arrive at a diagnostic and management decision and subsequently administer and advance the patient's treatment. So he has changed the definition in 2000. We said the clinical reasoning process is a dynamic one. It's a process, so things keep changing. Models on which clinical reasoning is based, number of models have been developed by various authorities, but most commonly referred to or discussed by Hicks and Jones. He postulated in 1995 as such. There are 3 conceptual approaches. The approaches for his model is by 3 conceptual approaches described by them. One is hypothetico-deductive reasoning, the pattern recognition or inductive intuitive reasoning. The third one is knowledge reasoning integration. This is a 3 conceptual approach while doing clinical reasoning they suggest as such. Hicks and Jones cite the suggestion made by Simon in 1980 that it takes at least 10 years to become proficient. Imagine 10 years to become proficient in this process, as well as the other skills needed to have professional competence and expertise. So always I used to remark to my final year students when I used to be in the institutions that on their graduation day, I said, you are going out, you are graduated only, but year after only you are going to learn physiotherapy. All these 3 years, 4 years, you wrote exams, did all your exercises in order to get a sheet, that is a degree certificate. But actually, you are going to learn only when you go out and practice as a physiotherapist. And imagine it takes, during our period, our massage teacher used to say, it takes minimum 7 years for you to become good hands to do a massage. So the same thing goes in 1980 by Hicks also. It becomes 10 years to become proficient in this process as well as the other skills. So it takes a long time for it to become a good physiotherapist. So don't think that I'm discouraging you, but you can, if you're good in skill development earlier also you can, but it takes some time. It's not that when you get a degree, you get all the skills as such. That's what I want to emphasize here. In hypothetical-deductive reasoning, it relates to how to respond to the clues given by the patient. So it is, that's what I said, it is the subjective examination. What clues the patients are giving? Let me take back the same example of osteoarthritis knee. Patient A says, when you are questioning, patient A says that I'm having pain in my right knee. and it is the morning. The moment I get up from the bed, when I make steps, I could not. It pains a lot, and after few steps, I can feel little better. But after half an hour finishing my activities in the morning, I feel much better. But as the days goes, it's not giving problem as such. Again, afternoon, after a nap, when I get again it starts paining. This is one scenario. Another patient B says that I'm fine, I could move my joint, there is no pain at all, but my nature of job is to stand and work. It within 45 minutes or 1 hour or half an hour, whatever it is, it starts gradually paining, and I could not tolerate more than 2 hours. Then I have to take a rest. So these two scenarios, this is what exactly the clues given by the patient, how you should respond. Because the first scenario, patient says that it is the static posture during sleeping, and when you try to move around in the morning, it gives, which is one of the classical symptom of a degenerative joint, where the joint becomes stiff. Whereas the other patient who is not having pain in the morning, he or she is able to go to the job and stand for some time, half an hour, 45 minutes, 1 hour, then it starts gradually pain. What does it suggest you? That is, the weight bearing, loading on the joint gives the patient problem. So, can we treat both the patient the same way? It's not. That's what you have to respond to the clues given by the patients. For which you have to do data collection. The data collection, we'll see the process one after another with examples. And for which I suggest, I feel I'm comfortable because I am trained in that one, the problem-oriented medical record. The conventional medical record gives a little chance for you to go for the hypothesis. But whereas the problem-oriented medical record, which is being practiced mostly with the manual therapist in the European countries, which started in somewhere 80s and 70s, and most of the people will try to, you could have seen in the books SOAP format, SOAP, with the body chart. That is based on the problem-oriented medical record. Then the subjective examination, which is actually all this data collection problem-oriented medical record comes under the subjective examination only, where the patient profile is important. All of you know very well why you need to get patient profile. It is just to correlate the patient's problem, not for anything else as such. And listing the problem is most important. I would like to say, as comment about this, in our practice, what are the problems? What is the difference between problem and a complication? The accepted signs and symptoms of any particular condition could be a problem as such. For example, take a post-traumatic stiff joint. Following a fracture of a bone, the surgeon immobilizes for some time. Eventually, the patient develops stiffness of the joint. That you could consider as a problem or a complication. I would consider that as a problem only because it is expected one. The issues coming out of health problem, because of the health problem, something comes, the pain, stiffness of the joint, muscle weakness, all those things depends upon the duration that should be considered as a problem. Whereas the same stiff joint, if the patient underwent surgery, immobilized, referred to physiotherapy, then somehow the patient could not continue. After 3 months, after 6 months, the patient comes back to you. So the one which was problem, joint stiffness, limitation of joint range, has become more stiff. That is the complication. So one should be able to analyze the problem as well as complication. We should not get confused with that one. One minute. Oh my God. Okay, some problem actually. Just a small hitch in this thing. Let me sort it out as such. I'm sorry about it because my hand touched over the keyboard. Let me resume that. Okay, coming back to the problems and this thing. So now we should be able to appreciate the difference between the problem and the complication as such. So most of the thing we try to treat the problems. So when a patient comes, before resuming the slideshow, let me say some points. When the patient comes as such, the patient's profile, we are here, patient profile. I told you, you should get proper patient profile in order to consider the disease problem. And listing the problem is very important, which the patient generated. Sometimes, what is the listing the problem is, when the patient comes, when you ask, what's the problem as such? They say, pain in my shoulder. They put the hand, pain in my shoulder. Okay. Anything else? No, I have pain in the neck also. So the patient says his or her problem is first pain in the shoulder. The second problem could be the pain in the neck. So like that, number of problems the patient can have. This is what the patient will say. Afterwards, when you put some questions, when they are not, when you think something, already your thinking process started that it could be because of this, it could be because of that. Then you say, do I get any other symptoms or like giddiness or, they say, oh yes, I do have. When I try, I'll try to get it. When I turn and see, I'll get it. So that is not the patient generated, that is the therapist generated. So this listing the problem is crucial part, and we'll have two examples how to list the problem, how to put it in the body chart at the end of the session. This is very important, behavior of the symptoms in 24 hours. What happens to the symptoms? You take, suppose the patient lists out 3 or 4 problems. You take it up, the prime one, which the patients think is very important problem. Taking that as a base, you should ask how it behaves in 24 hours. This is, after a few minutes, I'll come back to you why it is so. The behavioral symptoms will give you the sync factor of the problem as such. So when you say behavior of the problem, whether it increases or decreases, is it 24 hours problem, continuous, or is it intermittent? If it is continuous, during daytime or 24 hours or only the night time. So like that, you keep on questioning them, which talks about behavioral symptom. You could have seen in your experience by this time, when the patient says, I'm able to walk in the morning in the kitchen. When I want to sweep, when I bend, I get the pain. So otherwise, when I stand work, I don't get pain. So that is exactly that is what meant by behavioral symptoms. Then comes to the history. If you could recall your regular case record writing, the history comes first. After the patient's profile, immediately you will write history of fall from the tree, etc. Now, we were putting the history at the latter part of our subjective examination. This is the nature of onset. Nature of onset means what? Mainly, we have to put it under, is it inflammatory origin or is it a mechanical origin? This is a major thing mostly. As far as musculoskeletal problem is concerned, I am talking. It could vary with cardiorespiratory as well as, I'm not expert in those areas, so I may not be able to give good examples on that. So the nature of the onset is, what is that? Whether it is a mechanical problem or a continuous problem. That you should be able to find out from the history. Then the extent of tissue damage. The extent of tissue damage, you can see in terms of old records, if it is an injury, or if it's a chronic patient, how long the patient is having, or in your objective examination, you will find out there is the extent of tissue damage or changes. And progression since onset in terms of stage, rate, stability of the disorder. So when you say the progression since onset, you can say in two things: progression of the condition as such, progression of the problem compared with a year back or 6 months back. The patient would have got treated elsewhere for the same problem. For example, rheumatoid polyarthritis patient comes to you, on and off they are getting physiotherapy. So maybe 5 years back they had the rheumatoid, and what is the progress of the disease from 5 years to this date? That is one progression you have to consider. The next one is the patient used to have physiotherapy on and off. So when the patient says on and off, whenever there is exaggeration, or periodically I go and check my exercises with my physiotherapist. So how it is improved? Compare with the last 6 months, how is it? The range is reduced, range is more. So the progression, when you say here, it is both for the disorder as well as the patient's improvement in the condition, the problems. This is very important. Sin factor you have to find out. With all the information we got so far, we have to find out the sin factor of the problem. What is the sin factor? It is the severity of the condition, irritability of the condition, and nature of the problem. Why it is so important? If you could see, if you could have met a patient with acute pain, how they come? They face the grim's face with altered body language, with agonizing pain. So the sin factor gives the how much the tissue damage has happened. So when you say severity of the symptom, irritability of the tissue, and nature of the problem. Let us see one after another. When you say severity of the symptom, the latent period of symptom one has to assume. Patient A says, my pain is, before going for that one, you can use some tools now itself to find out the severity. The best tool could be VAS. The VAS is visual analog scale. The original VAS one has to use, not the modified VAS. You have to draw a 10 centimeter line without any marking there. Tell the patient on the left hand side it's a severe pain, on the right hand side it is the maximum intolerable pain. And the patient marks somewhere, you have to measure and note in your listing. That is exactly the VAS has to be done, not with the 0. When you say 0, no pain, 10 is the maximum pain, patient will be get biased and they will try to modify their answer. So make the patient blank, whatever they feel, they let them mark. Number one. Number two, the severity of when you use the VAS, it is the tool for the symptom for the moment, not yesterday's, not 2 years, not 2 weeks back. On that spot, what the patient's having, how much pain that has been marked. So it is the tool to be used at that time of your interrogation with the patient. So you know very well, if the patient marks somewhere between 0 and 3, you can call them as a mild. And between 3 and 7 or 6, you can call it a moderate. 7 to 10, it could be severe. Why it is important? Because the more number goes in VAS, that means the patient has got a lot of symptoms they could not tolerate and gives a lot of pain for them. So that gives an idea. We'll come back to that later, what idea. The other point is irritability. Irritability is how the damaged tissue or the tissue is getting irritated because of the problem. That means one patient, let's take the example of same low back pain. I do work in the kitchen. I work for about half an hour. Then I gradually get my back pain. And then within 5 minutes, I get very severe pain. I can't tolerate that one. So I have to take rest. How long? Say 5 minutes. So you work for half an hour, gets pain, tolerable pain. The pain is relieved in 5 minutes. That means how you could put the irritability. I would put that as a moderate, not very severe, because though the 5 minutes rest takes it off, though it is half an hour, in 24 hours, half an hour is very minimum. If the patient says within 5 minutes, I get pain and I want to take more than 30 minutes of rest, that means the tissue is more irritable. So the wordings, the information from the patient is very, very important. How you analyze. You know very well. That's what, here comes the cognitive factor. The severity and irritability, you know, when a tissue is damaged, how much it is being damaged. And the patient, what they say, you have to come to a conclusion whether irritability is mild, moderate, or severe, highly irritable. The next comes nature of the problem. As I mentioned earlier, the nature of the problem, mostly it could be a mechanical or traumatic in origin. So that depends upon, we have to plan out our treatment. The next one, once you find out this sin factor, the next step in clinical reasoning is grouping the patient, which is referred as the clinical grouping. What is that? Where the patient is a sin group, through range group, or end range group. You can see, correlate the sin factor of the problem, and you can group them under this. What is sin group? Whenever the sin factor, that is the severity of the problem, is high and the tissues are highly irritable, and usually the nature of the problem is traumatic in origin, those patients will come under sin factor, a sin group. That is, in VAS scale, you may consider that 1 to 3, 7, 8, and 10 patient, 1, 2, 3 could be a sin group patients. Whereas the patient is able to walk for some time, able to manage with the problem, and with a small rest, that problem goes off. Or if the irritability of the tissue is between 3 to 7 in VAS scale, they comes under through range group. Whereas some chronic patients who are having a chronic problem will always come under end range. Usually the end range patients will have fairly good amount of range, more than 75%. Whereas through range, it could be around 50 to 60% or 70% range. Whereas in group, they will have oddly about 10 to 20%. This is out of my own personal experience. I don't have any reference for this one. So how it helps? This grouping the patient is very important to plan your objective examination. That's the most important. Because when you group a patient in single group, you may have a group of tests available to confirm but you can't apply all the tests on the day one. Whereas in range of patients, you may employ all the tests on the patient. So how much you are going to do? I may throw upon certain other points as we go further. So I feel in clinical reasoning, the sin factor and clinical grouping is very, very important step in the process of making. So when you do this one, automatically you formulate a working hypothesis. What is hypothesis? Hypothesis probability, it could be like this. So let me go back to the patient A and B of osteoarthritis. What could be the working hypothesis for the patient? I could say static posture, where the tissues become stiff. That's the main. The patient does not have much pain. Their main problem is the stiffness of the joint in the morning. So I have good range of motion. The patient has got a good range of motion. The muscle power is okay. The gauge is okay. So what I will do for that patient? For that patient, I give them few exercises and insist them that whenever they try to get up from lying position or sitting position, or when they maintain a static posture, before making steps, they have to move the joints. Because the movement brings about the relaxation, the stiffness goes off. Whereas patient B, where on loading, the patient gets pain. That means already when on loading, when a patient with osteoarthritis will get pain, when their articular cartilage is being eroded or damaged. When they load the free nerve endings on the subchondral bone, that gives them pain. So what could be this thing? I mean, definitely, to my knowledge, in my view, the interferential therapy will not work. Just the exercise, quadriceps exercise will not work. It may be added, but the prime focus is advise the patient. You have to plan to reload the joint. How you to reload the joint? By giving a walking aid, walking stick. Plus, you have to give exercises in order to improve or in order to avoid further problems for the patient. So, same osteoarthritis patient, A and B, diagnosis osteoarthritis, but if they come to me, I manage like this. Simple exercises, advise them to move before any static posture. It could be lying, it could be sitting, or it could be standing, whatever it is. If they have static posture sometime, before they try to move, they have to move the individual joint few times, then that will become all right. So this is what, see here I formulated the idea, hypothesis that it could be the problem. Okay, one more example I'll tell you how I formulate the hypothesis. A patient says, I'm not able to lift my hand. Overhead activities is limited. I said, why? So I'm talking to a patient now. Suppose I have the patient, what's the problem? I have a problem in my shoulder. What's the problem? Pain. Okay, is it continuous or comes and goes? This is what words I used. So the patient says it comes and goes, on and off, pain comes. Then next question from me goes with when it comes, how it goes. The patient says that when I try to reach out the top shelf in my kitchen, I get the pain. The moment I just bring it down, it goes off. That gives my idea that, so the overhead activity or elevation through flexion needs more of lateral rotation, the lateral rotation of the humerus, which is known as the couple movement. The couple movement of lateral rotation is limited. That could be the reason. Or it could be the posterior capsule which is being tight. That how I suppose the patient says, putting the hand like this and says the pain is here, then definitely I would consider the first one. Or if the patient says, put the hand here, I find it difficult, my pain comes here, then definitely I consider the posterior capsule. So your observation right from the patient entering your room to you makes you to think, to frame your hypothesis. Is not only data collection, how the patient comes. So like this, the hypothesis has to be framed. I said here hypothesis or hypothesis because a patient tissue problems may not be only one. If it is only one problem, it could be a hypothesis. If more than one problem, it could be a hypothesis. For example, in this example, there could be a limitation of joint range, lateral rotation could be a problem, or it could be a tight structure, which a capsule is a problem, or it could be a muscle weakness, could be a problem. So there are three hypotheses I made it here. One, joint. Number two, capsule. Number three, muscle weakness. So this is what I call it as a making an hypothesis or clinical reasoning. So after putting these things in my mind, I have to choose appropriate tests and measures, which is the decision-making process. That is making an initial judgment hypothesis based on the clues. As I said, it's not only subjective information, it is the moment you see the patient, the clues we should be able to get. Go on, test to the working hypothesis. So data collection is an active process. It's not the number 1 day process. On the day 1, you do history taking, you write everything, and followed by you keep on writing your this thing. That is what the data collection as an active process. It is what the SOAP format is meant for: subjective, objective, analysis, and progress. SOAP format is given all the books. So of the problems, as I told you earlier, which problem is most important for the patient? It could be usually problem number 1 or 2. Take it as a base, and subsequent days following treatment, you have to do a quick test every day. That is a data collection here as such. So every day is a SOAP format, need not write everything every day. You take 1 or 2 problems, make it as a base, and try to find out what happens to that one by getting information from the patient. It may need to modify working. So as it goes, you may have to change your hypothesis as the patient works as such. So when you do this process, up to this, it is referred as a clinical decision making. To do what tests we call it, I put it as a clinical reasoning. The following discussion will be clinical decision making, maybe after this talk. So one more example I'll give you. A patient enters the department and reluctant to weight bear on the right lower limb, and also held in lateral rotation at the hip throughout the gait cycle. From initial observation, you note that there is a problem with the right lower limb and question the reason the patient has thought. That means whether the patient has come to you for right hip problem. You then test the broad-based hypothesis. What could be the problem? Broad-based here in this case, it could be a hip joint problem, or it could be a knee joint problem, because patient walks with the stiff knee as such, and bearing in mind that all possibilities that might cause this type of posture and gait. So So the patients with chronic pain share unique experiences, and all this skill comes gradually. Initially, it's very difficult, though it seems to be very distinct. So when I started this process, say about 20 years back, I started this process of clinical reasoning only after nearly about 20 years of my graduation, to be frank with you. But it took only 5 to 6 years for me to get little proficient in that one. So the patient with chronic pain share unique experiences. The therapist should keep his or her mind blank without biased thinking. That's the most important. I feel you never have a biased thinking of their favorite treatment options. Some people have the biased mind. I always give IFT, I always give ultrasound, I always give this. Then you without take the biased mind from your mind. I always say, see a patient as a new patient every day. Never think that a patient who came yesterday as an old patient, because a patient can give a new information every day. Listen, instead of listen to the patient completely and indulge them her planning rehab. So instead of listen to the patient, because if you have bias, you will have mind to listen to the patient. So always listen to the patient. Why you have to listen to the patient? That means you can use your cognitive ability to correlate with the clinical findings, then plan your rehab. So just always I give an example in the classes. Many times when you give a OP referral in the departments, neck pain, cervical C5, C6, ICT, IFT, neck exercises, without anything. When you, most of the patient, when you go, they will say, I never said my neck is paining. I said my head is aching. I came to hospital for my headache. So probably the other clinician had that idea that a particular age group of patients, when they put their hand here, it should be a cervical spondylosis. And at what level, they do not know. Usually it is C5, C6, C7. Order for X-ray. Next day they will see the X-ray. Before that they will write the treatment of traction. But if the patient comes to me, if I examine the whole spine, find out, I just go for, in this process, I may find out the patient has got problem of headache rather than neck pain as such. So if you have a biased thinking, you will never have a good, you can never make a good clinical decision as such. So listen the patient completely and indulge him or her. You have to involve. Of late, it is coming more and more in our country also, involving the patient in the treatment choice as such. So the clinical reasoning process is hypothesis oriented. The patient's data prompt the therapist, consideration of compelling interpretations, and clarified and tested through further data collection. Reassessment of management interventions. All those things is followed in the second part of the talk. In that, the second strategy is pattern recognition. The process of categorization of integral part of clinical reasoning. The process of categorization is one of the integral part of clinical reasoning as such. What is the categorization? You know, a set of signs and symptoms will be seen with most of the patients with the same problem as such. For example, if the sciatic nerve is compromised in the spine as such, when it comes out intervertebral foramina, then they will have some kind of similarity. Most of the patients, they will have pain. They may have radiation of pain, but the radiation could be, the site may be varied. Some may have more in the gluteal region, some may have more back of the knee, some may have at the calf level. That depends upon how much pressure is at the intervertebral foramen as such. So it is the categorization is very important. For a particular problem, health problem, the patient may have same kind of symptoms. So it requires the process of grouping, recognizing the similarities between a set of signs and symptoms, which is referred as you should have the ability of cognitive mapping. A so small analog cognitive mapping, suppose assume that you have something in our table. It could be mobile or it could be something. You just on seeing that what are the ideas comes, how you can develop the cognitive mapping you can develop. Take something on your table and chart out what are you can think of that one. You may think of the shape, you can think of the color, you can think of the price, you can think of the durability, you can think of the design. So about a particular thing, your thought processing can keep on going. That is referred to the metacognition. So that you should be able to develop if you want to be proficient in clinical reasoning. So it will be done, battle recognition will be done by knowledge, by past experience, which is referred as a forward inductive reasoning. Because the points which I told you is already you must have learned from the theory. In the classroom, the teacher must have taught you. Then if you are a clinician, already clinician, you could have experience. So this is out of knowledge. So Fox refers to this as a forward or inductive reasoning. As I told you, the low back pain. I already explained about the sciatica. One more example, the patient with ankle injury, post-injury, when the problems do not resolve in spite of early intervention to the appropriate musculoskeletal structures. Suppose a patient comes with the ankle injury, post-injury. You have done every good, done every clinical reasoning, you improved his joint range, you improved his gait is in all aspects is good, almost normal, but still the patient has got some problem of pain. What could be? Because all the musculoskeletal structures you have, so is there any other chance for the patient to have pain? Any other tissues? Yes, it could be neural component in that region. Though you are treated the best and you've given very good improvement to the patient, still the patient problem is not resolved 100%. So the problem could be, it could be a neural component in the region. What is that neural component in the region? Perform a neurodynamic test to confirm superficial cranial nerve, which is altered mechanism. In a colloquial term, you can say the nervous tissue mobilization, right? Highlighted by Higgs and Jones as this kind of, so you do everything, you had improvement, but still patient has got some problem, then you have to think of certain other issues, which is referred to the backward reasoning. The next one is knowledge reasoning integration, the base for continuous professional development. The knowledge is the base for continuous professional development. All of you will agree that one. The knowledge shift from basic science to clinical sciences. Obviously, you know, in health sector, this is what exactly happening. Whatever you study, unless it is being transformed to clinical science and skill, it's no use. In absence of such attitude, clinical reasoning ability could be a problem. That you have good knowledge, you have good experience or good service, number of years of service, but if you are not able to mix it with the clinical science, then this attitude, with that attitude, clinical reasoning ability could be a big problem. So what is knowledge? Knowledge is nothing but clinical reasoning is not a separate skill. It can be developed independently of relevant knowledge. The inexperienced clinicians, when I say don't get offended, the inexperienced clinician, when I say inexperienced clinician, what is experience? Learning is a continuous process as such. So one should correct himself or herself, change the attitude out of experience. If a person is not changing the attitude and it is not experience at all, it is nothing but number of years of service, So when I say inexperience, don't get offended. It could be just a passed out student, or it could be an individual with 10 years of service who can have very good knowledge store. Utilize the knowledge to reduce the problem. You'll be able to develop pattern recognition and store such details in long-term memory. So this knowledge store, how it becomes the how can store it in long-term memory is most important if you want to have a good experience. The long-term memory or past experience is made up of knowledge, which is stored in semantic memory, and experiences are stored in episodic memory. And students to rely upon semantic memory rather than the episodic, because as you gain experience, it can be episodic. That's why if a new graduate takes more than 45 minutes to evaluate a patient, I do the same patient evaluation in just 10 to 15 minutes. So that's because of the episodic memory. An experienced clinician rely on episodic memory, as I told you. Skills. The manual skills are needed in order to test the working hypothesis, because you are going to do an objective examination. Otherwise, where you are going to use a test and measures, unless you have a good skill of doing that one, like muscle testing, joint range of motion, or gait, etc., etc. So you must have good skill in that one. Which the skills are developed with proper practice. I won't say with practice, because improper practice makes a person always wrong. So you have to do the proper practice. That's why in physiotherapy curriculum, you could see that the theory versus practical classes, skill development is always 1:3. I'm not sure now how much, because a lot of changes in the curriculum comes. So the reason being the proportion of theory and practice is different, is more, is because of to have practice. Of course, as a student, I used to also think bad about repeating the same passive movement or massage, etc., etc. But it took nearly 10 to 15 years for me to realize why it is so when I started doing the curriculum as such. So please try to have a proper practice. So questioning, the patient will report with a global diagnostic label. This is what usually happens when the patient is referred or on his own when they comes, they will say, I am having sciatica, I am having this problem. So which is referred as the global diagnostic label. Gain some insight into the features of and possible causes of the problem by asking questions and actively communicate. Communication is very, very broad area, and I would suggest always that if you want to be good in communication, one should read the first or second chapter of Maitland's Peripheral Manipulation book. I think he talks about 60 to 70 pages on communication alone. How to communicate, how the patient will go from here. If you ask something, the patient may say something, and how to bring them back. At the same time, how you should be polite, etc., etc. So the active communication is very important. And listen without any prejudice. The example I already gave. By age, by this, by putting the hand, you don't think that the patient may have this problem. That is a prejudice. Appreciate irritability and severity of the condition. Always this should be bear in mind. A patient whom you think they are very having a lot of pain coming with you or other thing, don't bother about your routine. First give them symptom relief for a day or two, then you can go for clinical reasoning as such. What are the issues can come in communication clinicals? Problem that can occur with communication or asking closed questions. This is very important. Always ask a open question. When you say closed question, do you have pain in shoulder, they will say yes. Instead of that, simply, what's your problem? So asking a closed questions always limits the patient to give you more information as such. And asking leading questions. Yesterday you had treatment. Oh, your pain has come down. So the closed question is different and asking a leading question is different. And avoid. Don't give, the patient may think that he or she has to give a compliment for your treatment. They say, yes, pain is coming down. But when you reassess on SOAP format, you may find that the patient having tissues are still irritable or this. Instead of that, I put a question when the patient comes next day. Instead of reading question, how is the problem? The patient, if they are not able to answer you, say your problem is the same, or it is increased or decreased. The patient has to say only three things can happen for the problem. Either the problem has increased, or the same amount of problem, same amount of pain, or it is decreased. Only three things. So the patient will come out. After going from here, a couple of hours, I had more pain, and it has come down. Then I'm not happy with that one. So you say the pain is more pain. So is the same pain what you had, or is different kind? Because some treatment will give soreness to the patient. The soreness is expected. For example, if you give deep transfer friction, or if you give some particularly deep transfer friction or vigorous exercises, you may have soreness that should last or that will last for about a couple of hours. So you have to find out by putting proper questions. You should allow always to use the patient's own words to explain, to tell their problems as such. Suppose if a patient is going to a gym, he is doing gym, keeping him fit, and he comes and tells, I'm having pain in my ankle during flexion. But he shows the movement of dorsiflexion. For you and me, it is dorsiflexion extension, plantar flexion. But he, as a common man, he understood the dorsiflexion is a flexion. So don't get irritated. You don't stop him. Allow him to use his own words. Then you try to understand what he says and make an assumption. This is the most important. You should never make assumption of a patient's problem. And never, without, this is another important, but not allowing the patient to explain his or problem. Simply cutting them when they want to talk. But at the same time, some patients will try to go away from the main question. So you should develop that attitude. That's why I suggest the communication skill is very, very important. Identifying a sensitive information in an unsuitable environment. Suppose you are treating a patient, a female patient, or gynec problem, and next cubicle, another male patient is there, and the therapist treating the male patient is asking some questions, and the patient is answering, and you and your patient can listen what he is telling. So at that juncture, that time, if you ask some sensitive questions like her periods or her amount of bleeding, etc., she will find it embarrassing to answer you. She will try to hide because she may think that her answer the other person can overhear. So try to find out a proper place to have some sensitive information from the patient. And never have biased in any way. I need not say what is biased. So common errors, it could be vagueness, narrowness, rigidity, irrationality, wastefulness, insensitivity. See, these are all the errors which you will do. What are the points I said earlier? When you deviate from them, it will be good. See, when you don't allow the patient to give a proper answer, that will give you vagueness of the problem. And rigidity, don't allow the patient, if you don't allow the patient to give his or her issues, you become rigid, will not. And asking irrational questions and waste of time talking unnecessary. All those things should be avoided. All this is the common errors in clinical reasoning. Hypothesis categories that need to be considered could be a dysfunction, pathobiological mechanisms, sources of the symptom, and precautions and contraindications to objective examinations. So, what is a dysfunction? Dysfunction is nothing but because of some issues, the person is not able to do the daily activities. Suppose if elbow flexors are tight, if you don't have the full range of motion of elbow extension, then the patient will have elbow extension dysfunction. Or pathobiological mechanisms. It could be a tear of supraspinal tendon, or it could be impingement syndrome, or it could be entrapment syndrome. All those things should be considered. Source of the symptoms, from which joint, which underlying tissue it comes. For example, the so-called the common things piriformis syndrome. The source of symptom is compression of sciatic nerve at the greater foramina in the pelvis because of the tight or lack of mobility of the piriformis muscle. So here the source of problem is not the sciatic nerve. If you release the piriformis muscle, the symptom can get resolved. So the source of symptoms has to be found. The precaution and contraindications to objective examinations and treatment. This is what I was referring as a red flag and yellow flag, about which maybe next week we may talk. Then about prognosis. So at the end of the subject examination, you try to make an hypothesis, what could be the sources of problem and what are the contributing factors, and it is invaluable in identifying source and structural target tissue to be treated. And what areas and structures require testing in objective examination, that gives an idea. Also, how much and how strong, that depends upon the clinical grouping of the patient. This is one small, can I talk to Amal? Can I ask you some question?
Sir, you can carry on, sir. Please, sir.
Can carry on. Time is there?
Yes, sir. Yes, sir. Carry on, sir.
Another 5 or 6 slides are there, or I can shift it to next week also.
No, sir. You can carry on, sir.
Okay. It's a small problem-oriented medical record format. It's one method. If you can see that, the patient profile is given, then the problem is written here. Site, worst area, nature, and worsening or easing factor. It should be recorded the body chart. I'll come back to the body chart later on. So the moment the patient comes, you don't touch, you don't ask history, etc. Make the patient sit, find out all this and put it in the body chart. See, when we put it in the body chart, itself 50% of clinical reasoning would have been over. When you practice, you'll understand that. Then behavior related to time, that is a 24 hours behavior, and posture, if any altered posture is there, and activity. What are the activities of daily living? That you should find out next. Then specific question for it is for the lumbar spine. So the patient may not say the tingling sensation. If the patient doesn't say, if you think that it could be there, you can find out, is there any other problem like this? Give all the possibilities. They will say what problem they have. Then sudden anesthesia, very rarely the patient says unless you specifically ask. That's why it is a special questions or mixturation problem. So this gives an idea that the patient is having compromised cauda equina. Then, of course, drug history and previous medical history, etc. comes. Then only comes the onset of previous, then irritability, how long. So this is a format of way of putting clinical reasoning forward or problem-oriented medical record. If you could see that patient, so you could see that number one. Here, number one is this one. The patient says, this is intermittent It's not very big. Okay. Pins and intermittent and ache and sharp and stabbing pain is there. Is that problem you have? No, I have some.
Yes, sir.
I think up to the body chart, I'll stop here today.
Okay.
The form I will explain so that that will go well with the objective examination.
Okay, sir.
To sum up, I will sum it up, and I try to explain briefly about the clinical reasoning process and emphasized more on how to group a patient in a clinical group, as well as how to find out the sin factor. And I request you can send any type of questions to Mr. Amal Morgan, and we'll try to have half an hour open house the next sitting after completing the remaining part of clinical decision making as such. That may not take this long time. And Mr. Amal Morgan, I requested him to collect the questions to sort it out so that we can discuss certain issues. And I must thank the organizers for giving me this opportunity today. And I thank my teachers. I could see because of whom I am here today, Mr. Karison, and Miss Mary Chidambaram. Because of her, I learned a lot of things. I'm here today. My teachers and my colleagues, and of course my well-wishers like Ranganathan. I could see another. I could catch the face. So all my old students are there, and thank you very much for listening. I do not know how much it was helpful for you people who are having more than 10, 20 years of experience as well. Let us catch next week. Thanks, one and all. Thank you. Thank you, Amal.
Thanks a lot, sir. Thanks a lot for that crystal clear presentation, sir.